On behalf of TCHMB, I'd like to introduce the next session. Today we'll be talking about redesign of postpartum care and implications for clinical practice. I'd like to introduce the moderator of the session, Dr. Lynda Tyer-Viola. Dr. Tyer-Viola is the Director of Nursing at Texas Children's Hospital Pavilion for Women, and she also represents the TCHMB as an at-large member. Dr. Tyer-Viola.
Thank you. Before we get started, I hope everybody really enjoyed their lunch. It was fabulous, so thank you to everybody who was serving and taking care of us today. It was wonderful. I also believe in vegetables and that maybe we are not going to be in our coma after lunch because this is a very important topic to us. And then one more housekeeping before we get started is that on your tables there are forms that look like this. And what we're really looking for, and what Dr. Liu talked about, is that it takes more than a village. It takes leadership and engagement, and we would like you, or maybe your colleagues from where you come from, to join us and get involved with our collaborative. So please feel free to fill them out, and you can either leave them at the table or bring them up to the registration desk as you leave today. Thank you. So I'd like to introduce our topic today. So as we said, that our session is Redesign of Postpartum Care, Implications for Clinical Practice. Our leader of the session is Dr. Elaine Duryea. She is from UT Southwestern. Dr. Duryea is an assistant professor there and leads their maternal fetal medicine clinic at Parkland Health and Hospital System. Most of her education was with that system, which is fabulous. It's big and rich in Dallas, and she really leads an amazing team. I think that the most important thing is that her contributions are wide. I think something that each and every one of you knows is that she has contributed to Williams Obstetrics, which is a very big honor in your career. And so today we're going to focus on how we have to change postpartum care, and Dr. Liu said this is something that is essential to the care of women and children. Thank you.
Thank you. Is this how I move it forward? We'll see.
Yes.
Okay, so I wanted to thank TCHMB for the opportunity to speak here today about redesigning postpartum care and what the implications are for clinical practice and how someone might go along doing that. Oh, good. So the objectives I set for today's talk are pretty simple. We'll review ACOG recommendations for postpartum care, discover and discuss the barriers to providing this care to those patients that need it the most, and we'll discuss these barriers at the patient, clinic, and policy level. We will then discuss strategies for successfully implementing the recommendations, and my hope is that this will be a pragmatic and practical discussion on the updated recommendations for postpartum care, how to institute them in our practice, and why they are so important. We as a culture have a tendency to focus on the baby after delivery. As the mother of 2 young boys, I know how easy it is for women to kind of put off self-care to tend to a child. And as providers, we may in some ways encourage patients to do the same. I included this quote from Dr. Williams in 1903 because I think it's appropriate to remind us how drastic the changes a woman goes through in the postpartum period are and the risk associated with those changes. For that reason, I would like to start by briefly reviewing some physiology of the postpartum state. It's a little sciencey, so stay with me. After delivery, the vaginal epithelium does not really reform or reconstitute for up to 4 to 6 weeks until the ovaries begin to produce estrogen. In that time, we see involution of the placental site, endometrium and myometrium, and reconstruction of the cervix. If this process does not occur properly or the woman has an underlying disorder, there may be complications such as secondary postpartum hemorrhage that can be life-threatening. After delivery, it takes anywhere from 2 to 8 weeks for the hydronephrosis of pregnancy to resolve, as well as bladder injury from the birth process to heal. Pelvic floor injuries often fail to heal completely and may lead to incontinence and pelvic organ prolapse that needs to be addressed. Due to stretching from a term uterus, the fibers in the skin rupture and the abdominal wall becomes very lax, and that can take up to months to recover. In addition, marked separation of the rectus muscles can occur, leading to a diastasis, which may or may not get better. Significant hematologic and cardiovascular changes occur postpartum, reversing those extreme changes of pregnancy. Cardiac output drops precipitously to return to near normal values within 1 to 2 weeks. Diuresis reverses the volume expansion of pregnancy within 2 to 3 weeks, and the leukocytosis or elevated white blood cell count actually returns to normal quite rapidly. The hypercoagulable state of pregnancy is even more marked in the postpartum period and persists for up to 16 weeks, as shown in this diagram from a landmark New England Journal article by Camel et al. For this reason, a woman is most at risk for blood clots in the postpartum period. Lastly, lactation is a very complex process with the initial production of colostrum, followed by transition to a mature milk within 4 to 6 weeks. There are many neonatal benefits to breastfeeding, but maternal benefits also exist, including decreased postpartum weight retention, decreased rates of breast and ovarian cancers, and cost savings. However, many women experience great difficulties when trying to breastfeed, and complications such as engorgement, poor latch, and mastitis are not uncommon. Additionally, safety data on drugs during lactation is very limited, and it makes treatment of routine medical conditions more complex for these women. So, the postpartum period is one filled with dramatic maternal changes in physiology, not even touching on the social and emotional changes a woman endures. Again, something I can attest to. So how do we address this stressful period as obstetric providers? Traditionally, the postpartum visit is scheduled by the patient after her discharge from the hospital, and it's usually timed about 6 weeks after delivery to coincide with clearance to go back to work and kind of being done and ready to return to her normal life. In my training, I was taught this visit basically entailed 3 things: a depression screen, a pap smear, and contraception. It sounds easy. Women were then instructed to return to care when needed, such as her annual exam. In reality, the next time we see a lot of women is with their next pregnancy. The traditional visit, seems straightforward and easy, but I have to admit, after a while, I felt a little misled. To illustrate what I mean, I thought I would provide an example of a real patient that I took care of a few years ago. She was a 38-year-old woman who had just had her first child, and we brought her into the office at 4 weeks for a postpartum visit. It's our office policy at that time to see women at 4 weeks if they had a vaginal delivery. So her delivery had been complicated by an infant with a major fetal malformation, a cleft lip and palate, gestational diabetes, and hypertension. Her blood pressure had been normal when we sent her home from the hospital. You can see here that at her postpartum visit, her blood pressure was very elevated, and on her Edinburgh postnatal depression screen, her score was 11, and she answered that sometimes she thought of harming herself. You can see question number 10 down in the corner. On physical exam, she had some breast engorgement, her laceration was healing well, and she had significant painful swelling of her lower legs. She was tearful, anxious, and sad about her infant stay in the ICU and her breastfeeding difficulties. So, what needs to be done at this visit, right? This is where it kind of goes as a provider. We need to address her hypertension. We started medication. We set her up to monitor her blood pressures at home and send them into our nurse. I had to address her depression. We spent a long time talking about her symptoms, her risk, assessing her real risk of self-harm. You have to screen patients for domestic violence, intimate partner violence, and you have to refer to a psychiatrist, and in this case, I started medication because of her significant symptoms. We also had to discuss her breastfeeding and her neonatal issues. So we spent time talking about her infant's NICU stay, what her baby's status was, and the feeding issues, including her decreasing milk supply. And we talked about pumping, using my personal experience, referral to a lactation consultant, and we had that issue that we had to address as well. So, per the traditional model with the one postpartum visit, what else should I have done at this visit? I should have provided contraception counseling, including talking to her about which medications are appropriate in the setting of breastfeeding and her high blood pressure. I should have performed diabetes screening because she has a history of gestational diabetes. And I should have had that conversation about her finding a PCP or a primary care doctor that could take care of her once we are beyond the postpartum period. It's very obvious that I was not able to do all of those things in one visit. And I give this example because postpartum visits are often not straightforward. It's a very difficult time in women's lives, and the care that we need to cover during that one visit is unrealistic in a lot of cases. And this can be extremely frustrating for patients and providers. We have limited resources, limited time, and a busy schedule, and it's hard to find quick referrals for lactation services and psychiatric services. And in the end, at the end of the day, a lot of it's driven by what is the reimbursement for postpartum care. So this is not a new issue. This is something doctors and other providers and our nurses in our office have been addressing for a long time. So why are we talking about it here today? And what is driving us to make improvements? I think there are many reasons, a lot of which have been discussed already this morning. But one is simply that it's time to make a change and to do better. The time following birth is critical for setting the stage for long-term health and well-being for both the mother and infant. Postpartum care is unfortunately often fragmented among maternal and pediatric providers, with the communication between inpatient and outpatient inconsistent. Most importantly, there's a lack of attention to maternal health needs that should be alarming, because more than 1/2 of pregnancy-related deaths happen after the birth of the infant. And I think this is one of the major reasons why we're addressing this here today. So I thought we would just take a little trip down memory lane real quick. I'm sure a lot of you remember some of these headlines from the media. So we know that in the last few years, there's been a major focus on maternal mortality. That's one of the big reasons we're here, and it's all over the media, and everyone you talk to knows about it. Some of the headlines are less than flattering to those of us in the medical field, but I also think it was a really needed wake-up call and, a push to do better. And then what about Texas? We heard earlier a report of our outcomes, but to take a little trip back, I think a lot of us remember this headline or very similar headlines when we really found ourselves asking, are we worse than everyone else? And I believe last year Dr. Ollier talked here explaining that the answer is probably not. This group did a deep dive, and what they found was a maternal mortality rate of about 14 to 18 per 100,000 live births, which is well below the previously thought 38 per 100,000. They did find that African American women were still much more likely to be affected, with a rate of 28 per 100,000 women, and this was published in our most prominent journal in obstetrics because people are really concerned about this issue. In addition, they found that there were a number of women, when they pulled all this data and really looked at it, that died greater than 42 days postpartum. And those women do not get included in maternal mortality rates, but I don't think that information can just be discarded. So how do we reduce maternal mortality in Texas? It's hard to provide evidence-based care to women who don't or can't access care. And there are many barriers to accessing care postpartum. At least 1 out of 7 women in Texas are uninsured, and it's probably unrealistic to expect great outcomes when women can't access medical care. Put another way, we must improve women's health not only during pregnancy, but also postpartum and across their life course. This requires access to quality health care for all women, including preconception care and family planning, and possibly more important, as addressed earlier today by Dr. Liu, there is a great impact of social determinants in everything we do, and it cannot be ignored. But I'm here to talk about the ACOG recommendations for postpartum care. So in May 2018, ACOG published this committee opinion that updated and drastically changed their recommendations for the postpartum visit. They reinforced the importance of the fourth trimester and proposed a new paradigm for postpartum care. For women in the US, that traditional 6-week visit punctuates a period that is devoid of formal or informal maternal support. OB providers should assist women with accessing clinical and social resources that they need to successfully navigate the transition from pregnancy to parenthood. Like I said before, in the US, there's an intense focus on women's health during pregnancy, which is good, but care during the postpartum period is infrequent and late, and the focus tends to be centered on the infant. The committee states that the postpartum care should be an ongoing process, rather than a single encounter in time, and include services and supports tailored to each individual woman's needs. All women should be seen within 3 weeks of delivery with follow-up visits as needed, not just one, and a final comprehensive postpartum visit no later than 12 weeks after her delivery. They additionally comment that the timing of this visit should be, again, individualized and woman-centered. So what do women themselves think about postpartum care? Based on surveys, most women who attend postpartum visits report that they do not receive enough information about things like postpartum depression, birth spacing, healthy eating, importance of exercise, or changes in their sexual health or emotions. Therefore, when ACOG came out with their recommendations, they recommended a comprehensive approach to postpartum care. They said the visit should include a physical, social, and psychological assessment. This includes evaluating mood and emotional well-being, sexuality, contraception, birth spacing, infant care and feeding, sleep and fatigue, physical recovery, chronic disease management, and then health maintenance. It's quite a list, right, when you write it all down. They try to make it more doable to providers by providing this checklist that you see here. And it seems like a lot when you first look at it, but some of the things here we already do, and we just maybe don't think about it as being part of the postpartum visit. You see there's screening for depression, tobacco, and substance use disorder, and most providers do talk to women about breastfeeding at their postpartum visit, and when they're going to return to work. We just don't necessarily consider those things a checkbox on a list. And we should take credit for these things that we do. Every practice is different, but I could see a provider having a pre-filled note with drop-downs saying they discuss these things, this is what the woman wants, and I don't think it's unreasonable for us to do these, to accomplish all these goals as long as we have the resources that we need, and it can't just be the provider is the real take-home, it has to be a team. So, another thing that ACOG points out is that postpartum care really should begin prenatally. So there are a lot of topics that need to be covered that you can start talking about before the baby comes. They recommend going ahead and starting a formal written postpartum care plan before delivery. Topics that can be addressed prior to delivery include plans for infant feeding, baby blues, and emotional health, and the challenges of parenting and recovery from birth. Additionally, if a woman has chronic medical issues, you can start discussing who will be involved in her care after the baby comes and who will she be transitioning her care to for those issues. It's also recommended that conversations about contraception start by the 3rd trimester. And this is familiar to a lot of us who take care of Medicaid patients because we all know there's a form that you have to sign well before delivery in order to be reimbursed for postpartum sterilization. And so I think it's really important at 28 to 32 weeks, someone in the office start talking to her about what are our plans, educating her, because women need time to make good decisions. And it's been proven that counseling women ahead of time about things such as postpartum depression can be helpful. So you can see here in this randomized trial by Howell et al., mothers were randomized at the time of delivery, so postpartum day 1, to receiving either just written education handed to them, which I think we heard about in our small group, our patient session this morning, how that can be, receiving a stack of paper. Or women were given the paper but also had a 15-minute visit with a social worker who went over the paperwork and went over some possible coping mechanisms for baby blues and postpartum depression symptoms. And what they found is that women who received that 15 minutes of in-person counseling and coaching were less likely to screen positive for depression at 3 weeks, but also at 3 months and 6 months postpartum. So I personally, when sometimes you feel like it's hard to make a difference, I think this is amazing. A 15-minute conversation could be that powerful for a woman, just in, giving her a few coping mechanisms and ways that she can deal with stress in her life. And I think it should motivate all of us that we can impact our patients with less effort than we think, as long as we do it in the right way. So what specifically does ACOG say about the timing of postpartum care? We've already established it shouldn't just be one visit. So they say that it's not one size fits all, there's no recipe, and that care should be tailored to the individual woman's needs and medical conditions. They also suggest that the initial visit does not necessarily need to occur in person, that we need to weigh the benefits of an in-office visit versus the inconvenience of traveling with a newborn or getting out of the house when you still don't feel great. And so they really kind of throw it out there that, this virtual care is possible, and it doesn't have to be that old model of come in to the office. In fact, if you examine the diagram provided in the committee opinion, it simply states there should be contact with women in the first 3 weeks. And so I think that makes us think outside the box a little bit. Additionally, they give the caveat, which is important to think about, and there are a lot of neonatology providers and nurses in the room, that if the baby is hospitalized somewhere remote from the mother's home and where she received prenatal care, it's an obligation of her obstetric provider to help her find someone near the baby where she will probably be staying to get care and to address any acute issues that might arise. It is also noted that women with hypertension should receive a blood pressure check or evaluation within 3 to 10 days of discharge, and that women with severe preeclampsia should have closer follow-up. These recommendations are not new and have been in place from the time that the hypertension guidelines were published by the task force. And it's known that more than half of postpartum strokes occur in the first 10 days, so I think this is important information for us to consider when figuring out what's best for our patients. They also note that women with complex medical conditions may require multiple visits for those conditions, and that in order to address their complex medical care, thinking back to my other patient, in addition to the routine postpartum issues that need to be addressed. So I think it's sometimes easy when a situation is extraordinarily complicated, like those cases we heard this morning, to forget about the routine postpartum stuff we need to be doing as well. I thought it was important to point out that ACOG's not alone in making such recommendations. The WHO recommends screening of all women and baby pairs at 3 days postpartum, 1 to 2 weeks, and 6 weeks. The NIH recommends that all women be screened for resolution of baby blues by 10 to 14 days postpartum, and this is to facilitate early detection and treatment of postpartum depression. It's also known that undesired discontinuation of breastfeeding often occurs within 6 weeks of delivery. At least 20% of women who discontinue do so prior to their postpartum visit. And an earlier visit may provide an opportunity for support and to decrease that rate. The postpartum care plan that was outlined prior to delivery should of course be reviewed and updated after birth. The first components on that care plan, we're gonna just kind of march through it real quick, are to identify the appropriate team members and ensure postpartum visits are scheduled or can be easily scheduled. So ideally, your patient, maybe even before they're pregnant, before they deliver or before they leave the hospital, would have their postpartum visit scheduled. It's not something that you just kind of leave hanging and it's up to them to call and make that appointment. You also should include the provider's names, phone numbers, and addresses that will care for the woman and her infant postpartum. This is based on some information like a recent survey that said up to 25% of women postpartum had no phone number or any idea of exactly who they should contact if they had an issue. And this information can be easily recorded and given to the woman prior to delivery. In regards to postpartum visits, like I said, they want you to either schedule them ahead of time prior to discharge, or if you're going to not schedule it before she goes home, you need to give them specific instructions on how to call, when to call, what to say. So who is the postpartum care team? We said we're supposed to write down the names and the addresses and the phone numbers for the postpartum care team. So who might that be? Do you guys just want to? Her OB provider? Who else? Who's part of a postpartum team? Lactation consultant? Family. Thank you. Okay, so you can see here that on the other slide that the postpartum team is wide. It's her OB provider, which can be an OBGYN, a midwife, family doctor, nurse practitioner, and then of course the infant's provider needs to be on there too because we're trying to bring it all together, right? We're trying to give her all our information in one place. But also you need lactation support, specialty consultants, the MFM's contact information. If she has another medical condition she sees a specialist for, that needs to be on there. And behavioral health providers. We need to make it easier to access behavioral health. And some women may also benefit from a care coordinator or case manager or resources such as Healthy Start or Nurse Family Partnership. But how do you know if they would benefit from that? Well, it's important to identify her support network. You need to know who are her family members or her other community members that are going to help her take care of herself and the baby postpartum. And without asking those questions, you can't really know who needs a case manager or these other resources. And so asking those questions are really important. And this documentation can be done by the patient. They can fill it out and review it with someone in the office. It shouldn't be that difficult. It just takes that one extra step. So another component of postpartum care planning is infant feeding plan, right? We don't want to wait until delivery to try to figure out what our method of feeding is going to be. And providers and nurses in the office in the outpatient setting need to be able to counsel patients on the risk benefits of different feeding strategies. Women should be provided with community resources such as WIC, Mothers Group, and Return to Work resources. A woman's desire for future pregnancies, like I said, should be discussed very prior to delivery, and then again following delivery, taking into account any events that might have occurred. Additionally, her desires regarding timing of delivery or timing of contraception initiation should be discussed. In general, providers should advise women to avoid interpregnancy intervals shorter than 6 months and counsel about the risk benefits of interpregnancy intervals less than 18 months. But they're very quick to say that this is a woman's decision and we're just here to counsel her and that it needs to be tailored to her needs. There should be shared decision-making regarding contraceptive options. So the provider is the expert on clinical evidence, but the patient is the expert on her experiences and values. And at the end, the obstetric provider should ensure that she is aware of the full range of available contraceptive options, and the woman needs to be allowed to select the one that she feels suits her needs. The OB provider should briefly review the details of the delivery with every patient, as women may have questions regarding their care, and traumatic experiences can result in PTSD in up to 16% of women. And many of those women had what seemed like uncomplicated deliveries. And so I think this is something we overlook. A lot of times, as providers, we may bristle a little bit when people start asking questions about what happened, but I think it's really important for women to have an understanding, and it gives us an opportunity to correct any misconceptions they might have. We know that complications such as preterm birth, gestational diabetes, and hypertension should be discussed with the woman, including any follow-up evaluations that might need to be done, such as glycemic testing or blood pressure monitoring. And recommended interventions in future pregnancies need to be discussed. It's worthwhile, especially as it may impact her reproductive choices, to tell her about her risk in a future pregnancy if this pregnancy was affected. And that single little 6-week postpartum visit is probably not enough for us to perform all this counseling. Additionally, ACOG recommends that placental pathology should be reviewed with the patient if it was sent and explanation provided, and that the provider should make recommendations to optimize her health going forward in her life, whether it's an inter-pregnancy interval or not. And like I said, that would be making sure her sugars are controlled if she's affected by diabetes, and recommending weight loss and lifestyle interventions for those that are indicated. So as an example of how such care can be beneficial, this recent data from my home institution, Parkland, demonstrates the benefits of establishing glycemic control prior to future pregnancies. So in this study, we took all women presenting early for prenatal care and evaluated their hemoglobin A1C at the time of presentation. So a high hemoglobin A1C is bad, right? And we figured out that even though most women obtained excellent glycemic control, we have a very aggressive policy of admitting them to the hospital, getting them started on insulin the moment we know they're pregnant, right? Because we're trying to do well by this pregnancy and her and her baby. Despite doing that, women who presented with a higher A1C were more likely to experience preeclampsia, shoulder dystocia, and neonatal death. Okay. And the rate of fetal anomalies was double in the women with poor control compared to those with what I would call reasonable control, an A1C less than 10. And so this comes with obvious cost to our healthcare system and to our society. And so I think this was an important piece of information for us to say, control during pregnancy the moment she hits the door is not enough. It matters what happens before. And what comes before pregnancy is often a past pregnancy, and that's why postpartum care, extending it, is so important. So, postpartum care plans for women with chronic medical conditions. So they should be counseled regarding the importance of timely follow-up with a primary care doctor. So many times women are motivated to receive care and have such good access to care for their medical problems during pregnancy, but then afterwards may not obtain the same level of care. This includes women with hypertension, diabetes, thyroid and renal disease, as well as those women with mood and substance disorders. And they remark that a review of medication should be done, ensuring appropriate dosing and compatibility with breastfeeding if that's indicated. ACOG covers a lot of things in this committee opinion. So they also talk about the postpartum care plan and assessment of cardiovascular risk. And I have to admit that when I first read this was not something that really ever crossed my mind during postpartum visits. And what they point out is that pregnancy is a stress test. It's basically a window into a woman's future health. And additionally, many pregnancy complications increase her future cardiovascular risk. So a history of preterm birth, gestational diabetes, pregnancy-induced hypertension, that all puts her at risk for cardiovascular disease later in pregnancy. And it's important that we share that information with her. And it's also important to point out that when she goes to a medicine doctor 5 years from now, that doesn't go into the ASCVD calculator. And so this is our one chance to really convey that information to a woman, to document it in the medical record, and to make sure her future providers, PCP, takes it into account when they're treating her, okay? And then mental health. As previously discussed, anticipatory guidance regarding the signs and symptoms of depression and anxiety and coping techniques should be provided either prenatally or prior to hospital discharge if possible. Women should receive screening for postpartum depression at the first postpartum visit with swift management and involvement of either behavioral health counselors or psychiatry as needed. Women should be screened for tobacco use, including a history of tobacco use, because we know the rate of recidivism postpartum is extraordinarily high. Women are good at stopping smoking during pregnancy, but unfortunately are quick to go back. But we also know that our patients' behaviors can be greatly impacted just by a short amount of counseling in the office. And then pregnancy loss. They point out, which I hope is not something that most providers need pointed out to them, that women that experience a miscarriage, stillbirth, or neonatal death still need to follow up with an obstetric provider. They should be offered emotional support and bereavement counseling with referral as needed to support groups and counselors. It sounds easy, but it can be daunting to try to work these into conversations, and who do I send her to? What resources do I give her? And so I'm going to give you a little bit of information on that you might want to take with you. And so at this lab visit for these women, you also need to review any pathology results you might have. You need to counsel them on risk of recurrence. A lot of them need less counseling and more reassurance, and talk about their future pregnancy planning. They really highlight that follow-up in this group of women is vital, as the rate of postpartum depression among such women is extraordinarily high. So I'm lucky that at Parkland and UT Southwestern, we have teams dedicated to the care of women who suffer pregnancy loss. And so I reached out to bereavement nurses and nurses that I work with that care for these patients and asked them to give me the names of the resources they have found most helpful and consistent. You can see that there are very many of them here, and many of them have both in-person and online support groups, often in Spanish. And if you'd like a more extensive list of resources, please feel free to contact me or email me. It is recommended that prior to conclusion of postpartum care, the patient should identify the PCP that we talked about in a primary medical home if possible. So I think this is getting back to that idea that you really want them to be getting all of their care in some kind of cohesive fashion. And you want to make sure and refer to subspecialists as needed. And they really highlight putting your recommendations in writing and making sure that patient has them to take to their subspecialist so that there can be continuity of care. Finally, it is known that almost a quarter of employed women return to work within 10 days of delivery, and an additional 22% return between 10 and 40 days. OB providers should ensure women, families, and the women's employers understand that completion of a comprehensive postpartum visit does not obviate the need for continued recovery and support through 6 weeks postpartum and beyond. So just because they came in for a visit does not mean their FMLA has to end. So I think a lot of the providers and nurses and other people that work with patients in this room are thinking, okay, but we already do a lot of this, so this is not that bad. Hopefully that's what you're thinking. So the list appears long and cumbersome, but other than assessing the specific cardiovascular risk of the patient, I know that we routinely do a lot of these things. And that's why my first example visit is so incongruent with what I was taught as a resident, as an intern, because there are so many things you have to cover. And I think it's really great that, ACOG is coming out and saying that all these things need to be addressed, and that we need the resources to do so. So as far as ACOG's formal statement about policy changes in postpartum care, they state that optimizing care and support for postpartum families will require policy changes. They go further, stating that changes in the scope of postpartum care should be facilitated by reimbursement policies that support postpartum care as an ongoing process rather than an isolated visit. Additionally, an argument is made that provisions for paid parental leave, both parents, are essential to improve the health of women and children and reduce disparities with the maintenance of full benefits and 100% pay for at least 6 weeks set as a goal. Finally, they state that obstetric providers should be in the forefront of policy efforts to enable all women to recover from birth and nurture their infants. As Medicaid finances 45% of births in the United States and traditionally expires 60 days after delivery, the focus has been on Medicaid expansion programs. The idea is that if we focus on Medicaid, private reimbursement will follow. 31 states in the District of Columbia have adopted expansion programs, but 19 states do not offer extended coverage. Such policies have been associated with improved rates of low birth weight and preterm birth for African American women, as published in JAMA by Brown et al. And in June of last year, ACOG issued a statement to second the statement by the AMA that supports 12 months of postpartum coverage under Medicaid. I know we're a little short on time, so I'm going to go through this really quickly, and you guys are all probably very familiar. So where are we at in Texas? In 2007, Texas launched the Women's Health Program. 90% of the costs were offset by the 1115 waiver. This provided family planning as well as screening for acute and chronic conditions. In 2011, I think we know the waiver was not renewed by Medicaid, and the WHP was replaced with the Texas Women's Health Program, and primary care resources were delivered through EPHC. In 2016, Healthy Texas Women's was created, including auto-enrollment of eligible Medicaid for pregnant women clients after their pregnancy. This was all run on state funds until the recent approval by CMS of the 1115 waiver. So many women with Medicaid are eligible for benefits provided by Healthy Texas Women's, though they may not realize it, and I think that's important. So we've outlined this great new model for postpartum care, possible ways to make it happen, but it only works if women show up. About 40% of women do not attend their postpartum visit, and this leads to a variety of problems and impedes the treatment of their chronic health conditions and prevents us from detecting future ones. It decreases their access to reliable contraception, and the cycle begins all over again. Most disturbingly, attendance is worse among women with fewer resources, probably because they have to travel to your office to obtain a postpartum visit, and those women could really probably most benefit from the psychosocial components recommended in the committee opinion. So how do we increase engagement? We as providers and staff within clinics and hospitals can discuss the importance of postpartum care prenatally, during their delivery hospital stay, and really drive home the importance of follow-up. We should also try to schedule postpartum visits during prenatal care, like we talked about, and use technology. We have all this technology, right? We can use email, text to remind our patients of their appointments and to connect with them in ways that aren't traditional. And if patients have access to paid sick leave and family leave, they may be able to attend visits without fear of loss of employment or income. In 2019, TCHMB participated in an effort to identify and reduce barriers facing women who need to attend postpartum care. The results of the efforts are still pending, but I'm very hopeful they will help us identify more ways in which we can encourage women to participate in care, and part of which I'm sure will be providing education about available resources and considering alternatives to the traditional visit. So what can we conclude today? I hope you agree that though they appear daunting at first, the ACOG recommendations are feasible, and more importantly, they're vital to taking care of the women that deliver babies in Texas. We have identified barriers to providing this care, including the need for integration of psychosocial elements into traditional medical care, which can be done by using the entire postpartum care team and community resources. Additionally, funding and policy changes must be made to ensure adequate access is available to women, and providers must act as advocates for our patients. Finally, some strategies for success include organizing and implementing a process to document a comprehensive postpartum care plan. And in order to make this more feasible, that should begin during prenatal care, which emphasizes the importance of postpartum care to the patient. So I think we're running a little short on time. We were going to do a poll where you guys could text in, but I guess we'll skip that. Can we go to any questions?
Thank you very much.
Thank you.
So I know it's really tight for the afternoon. I think we can all say that postpartum care is very, very important. There's so many elements to it. It takes more than a village, but it's really about care coordination, because I truly believe that a lot of these questions are asked in silos in many systems. I can think of that our lactation team is amazing, and they call each and every one of our patients, and we could actually work more with that team to address the issues more up front before they occur. Unfortunately, we are out of time. We do need to shuffle for the afternoon. You can always reach out to us. Dr. Duryea will be here.
Thank you.
Thank you. So our next sessions, want to do the next sessions? Okay.